In children whom sexual abuse is disclosed or suspected, a medical examination may be considered. This film will help you talk to children and carers about what is involved in this, why they are done, and how they can be helpful. Medical examinations are done in different places, depending on local services and how recently the abuse took place.
Hi, hello, how can I help? I'm here for an appointment.
Good practice would involve the police or social care having an early discussion with a health professional with expertise on child sexual abuse. If the last contact or abuse happened recently, then the examination should take place as soon as possible, taking into account the child's age and wishes. This is for two reasons. Firstly, the child's health requires assessment, especially decisions around emergency contraception and other health needs. Secondly, physical and forensic findings are more likely if a child is seen soon after the abuse, ideally within 3 days. If the abuse is non-recent, including months or years previously, a medical examination can still be worthwhile. The consultation and examination can take time, and it is helpful if supporting professionals think about how the child and carer will travel to the appointment and make this as easy as possible for them. It is important that health professionals have information before seeing the child about the nature of the concerns or disclosure and other relevant supporting information. This may include referral or first disclosure details, details from an interview, or a number of concerns from professionals or carers collated over time.
So I've come with Lily. Lily's outside. She's 16 years old. Lily's gone to school this morning and she's disclosed that she's been sexually assaulted.
This exchange of information can happen face-to-face if a social worker or police officer accompanies the child. The expected role of the police officer or social worker while the examination takes place can also be clarified at the same time.
Hi, we're here to see Dr. Ali.
Okay, if you'd like to take a seat, I'll let her know that you're here.
All right, thank you.
A child can bring anyone they like with them, a non-abusing parent or a key worker, for example. Someone who can provide appropriate consent is needed for an examination, and this should be thought about in advance. For younger children, having a carer there lessens feelings of fear and anxiety. Adolescents can choose to attend without a parent or carer if they wish. A crisis worker, advocate, play specialist or nurse will meet the child and explain the process, including who will be there. The examination stages will be explained to the child. They will be reassured that they are in control and they can take breaks, skip a step or stop the examination at any time.
First of all, you would meet the nurse.
The health professional would introduce themselves and in acute or recent cases, they may be dressed in special hygienic clothes. Children can be put at ease in a number of ways.
I'm Dr. Ali, I'm one of the children's doctors. Do you want to
A
come
general
through with me and
history
we'll
will
have
be
a chat with
taken
your
from the
mum?
child and or the carer. This history and later examination may identify unmet health and emotional needs. The examination usually starts with some basic health checks.
Okay, Marcus, we're just going to check your weight and height, okay? So if you stand up there for me. That's lovely. I'm just going to look in your ears, is that all right?
In most cases, it is not necessary for the child to remove all their clothes or wear a gown. If they prefer, they can take one piece of clothing off at a time and put it back on before the next is taken off. In acute cases, professionals may ask for some of the child's clothing for forensic evidence. A general examination is important. In acute sexual abuse cases, physical injuries might be present anywhere on the body, which may require medical attention and be supportive of a child's account. A full examination may also identify findings that suggest non-sexual maltreatment, such as neglect. When it comes to the genital and anal examination, remember all and any parts of the examination are optional for the child. It's up to them. Most will experience a gentle touch only and no pain during this part of the examination. Children may be asked what words they use to describe their genitals and anus, and these familiar words may be used to start with. To make the examination more comfortable and standardised, they may be asked to lie in a certain position. Very young children can be examined on someone's lap. During the examination, nothing will be inserted or put inside a young child. Boys do not have swabs put inside their penises. It is uncommon for any to be put inside the anus, but may be considered in anal abuse, but only if tolerated and allowed. Older girls, past puberty, may have a small swab or the tip of a small soft plastic catheter put just inside their vaginal opening if they are able to tolerate it. A speculum, which is a plastic medical tool that may be put inside the vagina to enable a closer look inside the vagina and to do some forensic tests, is only considered in some acute cases of older girls, and not if they find it uncomfortable or do not want it used. A magnifying light with a camera on it will be used to help examine the child's genitals and anus. Consent and permission is sought from the child and carer for this. The camera takes clear images of the genitals and anus. These images are saved with consent for the medical records to support follow-up, for evidence, teaching, and sometimes for second opinion.
I just have to do some swabs. If you can pop your hand.
Forensic swabs may be taken in acute cases to collect any trace evidence of semen, saliva, blood, and DNA. These swabs may be collected from the child's skin, mouth, external genitals, and if they can tolerate it and if it is indicated, internal genitals and anus. Different swabs from some of the areas may be taken to check for infections. Boys and some girls may be tested for infections using urine tests only. It is important to test for and treat any sexually transmitted infections. Remember, the child can pause or stop at any time during the examination. In many cases, older children can take the swabs themselves, which can help them feel more in control and enable testing of those who may otherwise decline an examination.
Thank you so much for coming today.
After the examination and when ready, the health professional will ask them and their carer if they'd like to know the findings of the examination. This gives an opportunity to ask questions. The feedback from the health professional after the examination can help to reassure the child and their carer and reduce wider feelings of fear and anxiety about the physical impact of abuse. This reassurance is felt by practitioners to be one of the most significant aspects of the examination. A normal genital and anal examination with no signs of injury is the most common finding in children of all ages who have experienced sexual abuse of any kind at any time. Having a normal examination does not mean that abuse hasn't happened or that the allegation is not believed. For some children, if necessary after the genital and anal examination, blood tests may be done, vaccinations and pregnancy testing may be offered, and emergency contraception may be provided. General physical and mental considerations are important. For example, blood tests check for blood-borne infections like HIV and hepatitis B. The risk of suicide or self-harm is also explored, as studies report mental health concerns are often present. If a full examination has not been possible at this time, sometimes returning at a later stage can help build rapport and may make possible a future examination. After the examination, the child and their carers will be given advice and information about what will happen next. This can be an opportunity to educate, inform, support and signpost for the whole family. A number of follow-up contacts may be arranged depending on the child's needs. The referring professional should expect some feedback on the day in terms of findings and recommendations. This may impact on investigations and safeguarding actions, and may include suggestions for siblings or other children. Research from the lived experience of children who have experienced CSA tells us that for the majority, children reflect on the examination as a positive experience, highlighting care, compassion, sensitivity and feeling believed as the factors which make it so.